Assalamu alaikum. Hello, everyone. Thank you for joining. On behalf of CVU, I welcome all of you, and especially Dr. Professor Anuja Bhargava. She will be leading our webinar today. Just a little introduction for Dr. Professor Anuja. I'm sure I will not be doing her justice. She has a lot of achievements, mashallah. Dr. Professor Anuja Bhargava is the professor and head of the Department of ENT at ERA's Lucknow Medical College and Hospital. A gold medalist in MBBS, she holds several prestigious qualifications, including DNB, MNAMS, MFIILIPE, MAHE, FAIMER, and CHSE in USA. RFACE, CMCLFRI, she plays an active role in academic leadership as a member of the curriculum committee, clinical skills, lab in charge, IPE ambassador, and assistant registrar academics. Dr. Bhargava has received national recognition for her award-winning research presentations, has published extensively in peer-reviewed journals, and contributes to advancing medical education through her involvement in conferences like ICON, IPEPC, and NCHBE. With this, I welcome Dr. Anuja Bhargava. Before I give her the floor, a couple of housekeeping. Please, if you have any questions, don't hesitate to ask. If you are not able to interrupt her, you can add the questions to the chat, and I can also read it out to her whenever I feel there is a break. And also, I will be posting a Google form so you can add your name and your email. And please do double check the spelling because we have had where the emails were not working. So for your certificates. And in a couple of days, you should get a certificate. And if you don't get it, please do reach out to me. With that, I give the floor to Dr. Anuja Bhargava. Welcome, Dr. Anuja. Thank you so much for being with us and sharing your expertise.
Thank you so much, Sakina. Thank you so much, Sakina, for those kind words. At the outset, I would like to thank Zaidi sir and our Honorable Pro Vice Chancellor, Dr. Farzana Mehndi, for giving me this opportunity to share our experience at the ERA's University. A very good evening to all friends. Well, on the session today, which is called Simulation Enhanced Interprofessional Education, this will be more of an experiential learning for all of us than just a webinar. Sakina, I'm having a problem with moving the slides. Can I share again?
Yes, please go ahead.
Are the slides visible to everybody?
Yes, I can see it.
Okay, thank you so much. I hope I still have a problem in moving the slides, I think. I'm sharing them very well, but they're not moving for some reason, Sakina.
Do you want to share the slides with me and I can do it for you?
Yeah, perfectly. I would do that right away. Can I get a moment, please, for that?
Yes, please go ahead.
I've done that, Sakina. I think you would have received the deck. It's on your WhatsApp. Would that be all right?
Yes, yes.
Thank you.
Give me 1 second.
Friends, before we get on with sharing with the slides, I will still go on with the presentation. The session today is more of going to be, as I said, experiential learning. Very shortly, we would be having the deck on the floor, and I would be sharing a picture with all of you. Before I start on to that, let me share the learning objectives for today's session. Once the deck is on, you will interestingly see that I have written down that at the end of the workshop, the participants shall be able to know. This is not going to be a webinar, friends. We're going to be doing it in the mode of a workshop. No simulation or interprofessional learning can happen without collaboration. So the first learning objective that we're going to have is to identify the need for simulation-based education, enhancing IPE in your respective curriculum, which means we have to identify which is the area within your curriculum which you would like to impart by interprofessional education A. B, another aspect to it, which would need simulation as a teaching learning method. Can you please change the slide for me, Sakina?
Yeah.
Thank you. So the second learning objective would be, in order to implement simulation-based education, it is very important that we understand the principles of simulation-based education and interprofessional collaborative practice, and how this has to be used as a modality for imparting IPCP. The third objective would be, what would be the teaching learning methods that you would be using? Fourth, the assessment strategies that you will be implementing. And most importantly, as I said, to understand the principles of debriefing. Friends, you've already had a wonderful session on simulation. And as I always say, debriefing for me is the most important part of simulation-based education. If I do a particular scenario for 30 minutes, 30 minutes I devote, friends, only for debriefing. Please change the slide. Now we see a picture, and right in the extreme corner, you see a logo which is there, and which is interestingly basically words put together that we did out of a webinar, which you see many words: progress, together, success, beginning. And that's, I think, the best way to define interprofessional collaborative practice. Now, let's get on to the working. We see two pictures right there. The first one says, too many cooks spoil the broth. The second, as we all recognize very well, getting our memories back to 2019, that is a picture almost showing us the COVID-19. Can somebody share on the chat box that how do you think the two pictures could be linked? Any thought that comes to your mind? Sakina, I would need your help to help if what is there in the chat box. Come on, friends, get going. Sakina, please share the chat as it comes along. Okay, so that is Shubha. I can see the chat. Thank you. So that's teamwork. Yes, Shubha, it does talk about teamwork. So come on, friends. Any word that comes to your mind as you see the picture? One, of course, is teamwork. Okay, it's not about the number of members in a team, as Sir says, but it's about proper teamwork and collaboration. That's from Madam. I'm sorry about that. I could not pronounce the word very well. We have somebody coming from, we have Siyok telling us, if we work in collaboration, even mountains can be moved. Yes, friends, that's true. When we just, if you get your thought process to what was happening before COVID, we always said that too many cooks spoil the broth. But it was COVID-19 that gave us the experiential learning, the importance of working in a team with collaborative practice. And I think all of us would agree to this, that there is no better example that we have at the moment than the COVID-19 itself, telling us that the most important part of team health professional education at the moment is learning to work together. Please change the slide. Okay, now we come to the next. This is a particular diagrammatic representation that tells us a step-up approach, how we move from interprofessional education to collaborative practice. Friends, interprofessional education, as it is defined in 3 or 4 words, if you ask me, first thing that we emphatically emphasize on, and I have some of my co-fellows with me here from the Mahi family, is that interprofessional is one word. There is no hyphen in interprofessional. For interprofessional education to happen, we have to integrate it within the curriculum, moving on to collaborative practice, and that gives us an improved healthcare system. Please change the slide. Sakina, please change the. Okay. Now, again, I want your thoughts working. What would this particular picture give us? Any thoughts? Come on, you have to get active with your fingers on the chat box, friends. What do you think of the picture? What is the first thing which comes to your mind? Okay, that's good handing over. Okay, madam has come up with here is a gravely a lady brought by an ambulance to the ER. Okay, come on, friends. We have more of them. Teamwork. Still more to go. Still more to go. Okay, in the ER, there are many professionals that are working together with the aim to treat the patient. Now, I would take a moment of yours and imagine yourselves right outside the ER, and we have a patient arriving with epistaxis. Zedi sir will relate with me because we are both with the ENT background absolutely passionately. When you have a patient arriving in the ER with epistaxis, ladies and gentlemen, the first person to receive the patient is not the ENT surgeon, but this patient is received by a ward boy. Patient moves from a ward boy onto the wheelchair, escorted by a nursing staff onto the chief medical officer, then attended by the ENT surgeon. So we have to realize that the minute we are in the hospital settings, we will be a group of people with different professions working together, aiming to deliver the best of healthcare. Please change the slide. Now we start with the definition of interprofessional education. We have a numerous frameworks, friends. I will be talking about them from time to time. The first one is the WHO. WHO came up with a definition for interprofessional education as an approach where students from two or more professions learn with, from, and about each other. One second point emphatically telling all of us is that having a group of people sitting together, nursing, allied, medical, and doing a particular session together. For example, if I'm taking a session on tracheostomy, I have a group of students from the nursing background. I have a group of people who are OT technicians. I have a group of people who are ENTs, and I'm trying to deliver them tracheostomy. Friends, that's not interprofessional. Interprofessional is as three words, which I want all of you to take back: with, from, and about each other. Now let us go and decode how does this with, from, and about each other happen. The next slide, please. Interprofessional started way back since the 1970s. The Institute of Medicine in the US came up with the concept of educating for the health team. CAIPI was the first IPE center established in 1987 to generate, synthesize, and translate the evidence base for best practice for interprofessional education and collaborative practice, which means in different parts of the world, whether it was the United States of America, whether it was the United Kingdom, we realized, because CAIPI started in the United Kingdom, we realized the importance of teamwork. The next slide, please. 9898 for hassle-free food booking and more. Somebody, are we sharing something?
Please, can you mute everybody? Can you mute yourself?
Thank you. Thank you for that. Now, when we talk about, we were talking about how we had different systems coming up with the definition of interprofessional education. CAIPI amended its definition of IPE to occasion when two or more professions learn with, from, and about each other to improve collaboration and quality of care. So the next step is that we move to the quality of care. And finally, it extended its definition when occasions when members or students of two or more professions learn with, from, and about each other to improve collaboration and the quality of care and services. So we move from the delivery of healthcare to quality of healthcare services. The next slide, please. Please change the slide. We've covered this. Thank you so much. The next slide. Okay. So we have two important pillars of interprofessional education. One, learn with, from, and about each other, which I've said for the 12th time, I think, during the first 12 minutes, to improve collaboration and the quality of care of services. Now, the question arises, how am I supposed to do that? I am an ENT profession. I have gone there to do tracheostomy on a patient. I've been called in the ICU to perform tracheostomy on a patient. I would think I know how to do my job the best. I am the surgeon. I do the tracheostomy. But ladies and gentlemen, do you agree? I would take a pause again. Do you think tracheostomy is just the preview of an ENT surgeon? I pause here. I would want all of your suggestions on this before I move ahead. Please get back to the chat box. This is not, friends, this is definitely not a webinar. This is a workshop. Okay, so we have, no, this is definitely not just the domain of an ENT surgeon. Then who all do you think contribute to a procedure like tracheostomy? Even if you're not of the ENT background, I think we have many people who can share their inputs on that. Please. Okay, come on. Yes, it is. A nurse is also involved, maybe respiratory therapist if needed. Very well said. Nursing, very well said. Come on, nursing care. Thank you, ma'am. Thank you for that. Yes, we have people more. Okay, thank you, Seo. Many other healthcare workers are also involved. But what we need to understand that whenever we talk of a particular procedure, you talk about an aspect of healthcare. Friends, we need to understand who are the stakeholders. Getting to do teamwork just doesn't mean that you need to understand that everybody is a part of your team. The first thing is to get to know who are the stakeholders. So I think in tracheostomy, we would have an ENT surgeon one. I would have nursing staff, as you very well said, physiotherapist as a respiratory therapist, very well said. I would have an OT technician, and I think maybe even a dietitian. Because the goal of performing a tracheostomy is just not able to successfully put the tube, get the saturation, but ensure that this patient improves, patient heals, and ultimately gets decannulated and is discharged without a tracheostomy tube. Please change the slide. Thank you. Sakina, can you please change the slides? Thank you. I'll rush through this. We've covered it. Thank you. The next slide. Please change the slide. Yes. Now, I would pause here. Now, to be able to work together, performing tracheostomy, the most important thing is I should know 4 pillars of interprofessional collaborative practice. Now, these 4 pillars are known as the competencies of interprofessional collaborative practice. Let me decode it better. My co-fellows who are a part of my FAMA would understand this much, much better. We've lived with it. What are your roles and responsibilities? Me as a surgeon, I can do the tracheostomy. True. But I need to understand when I'm doing interprofessional collaborative practice, what are the roles and responsibilities for my other professions? My nursing staff would be taking the consent. My OT technician would be there to give me the instrumentation, provide me the tracheostomy tube. My therapist is going to be there to make sure my patient has good breathing and is able to breathe, maybe ultimately spontaneously. So I should know the roles and responsibilities for myself and my teammates. That's the first pillar, friends. Second pillar, you have to have any care with the basic principles of applying ethics, which is extremely important. I will come into that in detail. Third, you need to have good communication amongst your team members, communication with the patient relatives, communication of the team with the patient, communication of this team with the community. Because the ultimate goal of having an interprofessional collaborative practice, friends, is to improve the quality of care, is to improve the society healthcare. So there would be an improved healthcare system. This particular diagram, which is shown by bar, shows that each of us has three set of competencies, which means the surgeon would be sharing certain common competencies with the nursing staff, with the OT technician, with the therapist. There would be certain competencies which we need to deliver together, which are called collaborative competencies. And third, there would be certain competencies which are called as complementary competencies. That is, we complement each other. Please change the slide. Now, I would like to stress on this is the values and ethics is when people, that is a team, is working to maintain a climate of shared values, ethical conduct, and mutual respect. Friends, I would like to take a pause again. I would get you back to the chat box. Do you think all of us, whether we are of the nursing background, of the medical background, do you think we are placed at the same hierarchical system? Do we have a parallel hierarchy as far as healthcare professionals are concerned, irrespective of which part of the world you are staying in? Come on, friends, I want you getting back to the chat box. Yes, I want some responses. Please, friends, it gets interactive, gets interesting for all of us. Yes. Actually, no. Yes. Holistic approach, patient safety. Friends, the question here is that do you think doctors, nurses, the allied healthcare professionals, are we at the same platform? Or do you see a hierarchy that the doctor is placed on a podium which is much higher than the others? What's your thought on that? Quality of healthcare, thank you. No, yes, definitely. I agree to what Shubha said. I feel that in most of the countries, we, the doctors, are placed at the top of the hierarchical system. But why is that so? We need to understand that when it's ultimately the healthcare, improved healthcare is the goal, why aren't all the healthcare team members placed in a flattened hierarchy? The next slide, please. You can move through the slide, Sakina, because we've covered the competencies. The next one, please. Still the next. Yes, still the next. Still the next. Okay, so that's the summary which you see the competencies of IPCP. So the first point at the end of about 15 minutes of the maybe the seminar, I would like to put is working with, from, and about each other. Second aspects, the different way how we came to different aspects of defining interprofessional collaborative practice. There was a definition by WHO. There was a definition which came up by CAI-P, and there will be a definition coming by the Interprofessional Collaborative Group, which we will be discussing, which was the group which went on to define the competencies which we have discussed. The next slide, please. Okay, now this particular article was very interesting to me, and I will be coming to the next aspect. I did my fellowship in 2020 and to 2022, and that was the most challenging period in the world for most of us. We were amidst the COVID-19. And friends, I would like to very proudly share, I belong to the batch of Mahi Fammer, which had my director as Dr. Siraj sir, and I've been trained by Dr. John Gilbert. I would request everybody to please mute their slides. Please mute yourselves. You can enjoy the webinar a little better. Thank you, friends. Thank you for your patience. So we would be sharing that when we were during this period of the COVID, I think we would request to please mute your slides. Please mute yourselves, friends. Okay, thank you so much. So when we were amidst the COVID-19, we were the only batch of Mahi Fammer India, which was a completely virtual program, friends. We started virtually. We ended the fellowship virtually. We were given our certification virtually. But even our director today believes that we are the batch who is most closely connected. When we meet each other, it is as if we are a part of each other. So what was it that we were able to connect to each other? Was it just our frame of mind that we were working together? Did we not need to see each other? Could the virtuality be so real that we are able to get into the real collaborative practice behavior? Now, when you talk about a collaborative practice behavior, It is a change that you have to bring into yourself. I think I have not been taught medicine in a manner where I was taught to work in team. I wasn't taught. I accept the fact. However, I have trained myself, I have evolved, and I have learned to work in a team with mutual respect. But I need to devise a way in which I can work in a team. If I'm caring for a patient where I am the only profession which is supposed to deliver the care, if I'm supposed to take the history, write the management, I'm not working in a team. So let's think of something interesting. And that's when the simulation based education came as an important way to deliver interprofessional collaborative practice. And that's what it says, utilizing simulation enhanced interprofessional education to identify differences in healthcare students' collaborative practice behavior. This is one of the many studies which has used simulation as a modality to training for interprofessional collaborative practice. The next slide, please. Now the question arises, we do understand interprofessional education is very important. It should be a part of the curriculum. It should go longitudinally to the curriculum. But are we doing enough? How many of us do you think have an interprofessional collaborative program within your curriculum, friends? Let's put your hands up or maybe something in the chat box. Again, the chat box time, friends. Can you put some notes that do you have an interprofessional collaborative practice program within your curriculum? Rarely. Needed, sir. Thank you for that. I would also say that very little. I agree. Even I don't. I think internship in the National Medical Council curriculum is the best example of interprofessional collaborative practice. Dr. Seo, madam, thank you so much. Yes. No, madam. I think most of us agree that we don't have. Yes, many schools in the western part of the world, the United States of America, Australia, Singapore, yes, are coming up with an interprofessional collaborative program within the curriculum. Not my institution, but we have implemented in other institution. I was affiliated many years. Very congratulations, madam, and you've taken a wonderful step. I think interprofessional education evolves you, makes you a better person, if I say. Thank you. The next slide, please. Thank you. Now, this is an interesting model. Yes, this is very true. Thank you, madam. That's very true. And this is an interesting model. I would like to draw your attention. This is from a document I have taken, which is from the Interprofessional or Collaborative Practice, which talks about it. Now, my point to all of you is, okay, you put interprofessional collaborative practice within your respective curriculums. It could be medicine, nursing, allied. What do you get out of that? What is your output? You take a student, you train him longitudinally across 4 years, 5 years. People from the Indian scenario would relate to the community medicine program. Community medicine in the Indian curriculum is trained from the first year, friends, almost to the final year. Why? Because it is needed to be integrated longitudinally. And that's what we are advocating for. This is the time. This is the moment where interprofessional collaborative practice needs to be integrated into the curriculum longitudinally. What do you get at the end of 4 years or 5 years? You get a mentee who is trained, or healthcare professional who is trained to do interprofessional collaborative practice. Next point, what happens then? He gets into the system. He starts delivering healthcare with interprofessional collaborative approach, which is called interprofessional practice. So IPE leads to IPCP leads to IPP. And then what is the final outcome? With your policies integrated with interprofessional collaborative practice, ladies and gentlemen, what you will have is an organizational system with improved healthcare. That is when you understand that how the educators, the students transform into healthcare professionals, transformed into a system where policies will be implemented. And finally, you get a system which has improved healthcare. Next slide, please. So what do I want, if you ask me? Friends, I think this season that we have in the Indian subcontinent, we are having rains. We are lucky. And despite global warming, we're still getting some rains. Well, I think what is my cause of concern right now to my city? I live in a beautiful city in the northern part of this country. It's called Lucknow. It belongs in a state called Uttar Pradesh. And I'm very proud of this. And at the moment, what is worrying me is that recently I was driving to work and I heard an advertisement, which was from a pathological lab, telling me that testing for fevers has begun. My first reaction, I called up my colleague, who's the physician chief in my medical college. I said, has the mosquito menace begun? Do you think we're getting cases? She said, yes, it is. Well, do you think the community problems need to be dealt with an interprofessional collaborative approach? The question is again open to everybody here on the chat box. Something like dengue, something like malaria, something like typhoid. Do you think this requires, yes, sure, of course, some more friends, something like vertigo, something like allergic rhinitis, something as common as headache, friends? And I think now is the time that we realize it should not be in a container. We have to move out of our silos and we have to deliver healthcare with an interprofessional collaborative approach. First, we accept it as the mentors, and then we devise the program and we implement it through simulation, which is the next 15 minutes of the webinar. Next slide, please. Okay, so I take you on a ladder. I would request everybody if you can please mute yourself. Because please mute yourself. Thank you very much. Thank you for your patience. Now that's something which I love. Well, I am sharing my journey as I go along. My mentor is my Honorable Pro Vice Chancellor, Dr. Fazana Mehndi, as I very fondly call my friend, philosopher, and guide. The time came, I finished my fellowship and I was introduced to Zaidi sir. I came in contact and I started learning with him. He reminds me very much of my grandfather, is exactly. And I started realizing that interprofessional collaborative practice advocacy is not enough. Well, my Pro Vice Chancellor, she advocates skill lab learning. We have proudly made a low cost skill lab within our institute. We even have an interprofessional skill lab within our university now, of course. So we went on and we realized that, so we need to take it in a different picture now. So we need something else. Something was missing. Interprofessional collaborative practice, yes. We developed the module, we published the module, but something is missing. So we thought, okay, we need to build on simulation. She encouraged me. She said, do something else. So I went on to do my certification from the US from something called the Simulation Society of Healthcare. We had a wonderful webinar with a lady sharing us the inputs. So, and I was, by her blessings, I became a chassis, which was successfully done. But she said, don't stop there. You need to do something else. I did a program with the Harvard last year, which was on simulation. And that's when we realized we got what we wanted. We had an exact insight into how to implement simulation. Okay, now the National Medical Council within the Indian subcontinents makes it compulsory for every medical school established in this country to have a skill lab, friends. We've been given a set of mannequins for all the medical students. We've been given a list of all the certifiable skills which they are supposed to know, including teamwork, including communication skills. But we've even talked about debriefing, but we don't have a structured program to deliver the teaching learning of these skills. We had an extensive way, we went across the country, everybody as a part of the council helped, we devised. So taking this journey forward, the next slide, please. I will take you on to the world of dream, which I called is simulation. According to me, if you ask me what is simulation, friends, I call simulation as a paradise. Simulation is basically from a Latin word, which means to copy. We've all copied as friends. As a child, when I was a young child, I was copying my mother sitting on her dressing table, trying to use her makeup. We've had the boys using their father's shaving kit. We've all played with dolls. I think I've had my favorite doll. I remember her name as well. Do any of you remember the name of the doll that you played with? You can put that on the chat box as well. Anybody remembers the name of the doll that you played with? Well, mine was Carolyn. I'll tell you that. My father bought me that doll, and it meant the world to me because, yes, Monica, that's nice. That's nice. And my Carolyn could cry. I could make, okay, that's nice. I don't know how to pronounce that. Well, that will be show melee. Okay. Anybody remembers? So imagine the number of years back that you used that particular article, but that remains as a part of your frame, friends. But if you try, okay, it's a German for sleepy little girl. Thank you so much. That's why, well, I couldn't pronounce the German word. I'm sorry about that. So imagine if you try to recall and if I ask you, what was the last time you played something with a friend at the age of 4? Okay, you won't be able to recall that so vividly. But why this doll? It remains in your frame, friend. So with the help of the simulation, as I call the paradise, we create a mental frame within our mentees. We take them to a virtual world in reality. And this is my favorite line. I'm not talking about virtual reality, but I create a virtual world for them within the system. For example, if I have to create a minor OT, I have to make it look real to them. Now, how do I make them look real? It has to have the same kind of furniture. It has to have the same kind of instrumentation. It has to have the same kind of order. It has to have the same kind of sounds. And my patient comes and I have to make it as similar as I can. The next slide, please. Now, please change the slide. This is some history that we had shared about the simulation. I can go on. So what I understand is simulation is creating an experience within your frame. That's behavioral science, friends. Simulation, I call as behavioral science. So if you're able to create an imprint with realism as close as possible to what your student is going to do, and then leave him to reflect and finally go through the corpse cycle of analyzing and getting the conclusion, you are letting him develop the critical thinking which he needs to have to deliver the clinical decision. Next slide, please. Now, this is the slide which I feel is the soul of this presentation. It has on top two terms, realism and fidelity. Degree to which a simulated environment mimics practice is realism, friends. Realism could be furniture. Realism, as I said, could be instrumentation. Realism could be mileage, which is things like blood, vomitus. It could be a burn that you have created. And to fidelity is the degree of realism. Now, this fidelity, if it is used to describe the particular mannequin that you're using, it could be a part mannequin, it could be a whole body mannequin, that is fidelity. Fidelity could be low fidelity, mid-level fidelity, or high-level fidelity. We have beautifully, I think, high fidelity mannequins which are able to give you the realism of the hair of the patient. It gives you the eye blinking. It gives you respiratory rate. It gives you heart rate, and it's able to create the scenario for you. Now, if I tell you, I'll get you back. How many of us have watched the Jurassic Park Return? Well, I haven't. I think I should be able to see it next week. How many of us have watched the Jurassic Park? I watched the first one, which came way back in 1994. So I'm really looking forward to see the dinosaurs. Have they changed a bit? Me too. Yes. I was just wondering how much they changed over the years. I haven't. I look the same almost. Okay, me too. Some more people? Okay. Well, when you go to see Jurassic Park, I feel that's wonderful realism. You are taken into the world where the dinosaurs existed. And most of the theaters will promise you an experience where you feel you're coming out of the Jurassic life. And that's why you have a series of the Jurassic Park. And that's exactly what you need to give to your students. You have to make them feel that they just experienced seeing a patient of epistaxis walk into your ER and they treated it. And we are able to deal with that. I'll get back to this answer. I will tell you an experience that I went through on the Hollywood Boulevard in LA. I went through an AI experience where I went into the Jurassic World, but it was not as fantastic as the theater I felt. Well, getting back again, I will be using 3 terms for realism: physical, psychological, and conceptual. Physical. Physical would mean equipment, as I just said. There should be a couch, for example, in a minor OT, a suction machine with the sound of the suction machine. You cannot have a minor OT sitting within the classroom. I cannot give my patient to see epistaxis patient coming in a demonstration room. I cannot expect him to treat in that manner. Psychological. Psychological would mean that the patient, that this your mentee is able to relate to the surroundings, that yes, this is where I am. Can you please change the slide? I'll get back to that again. Okay, thank you so much. I was wanting these 2 terms here. Now, when you are able to create an environment with the necessary realism, fidelity, you need to do it with 2 very important pillars: psychological safety and safe learning environment. What does that mean? I would say the ability to say what you want, the ability to express yourself, friends, without the fear of being reprimanded, the ability to make a mistake. I think that's very important. That's the frame I give my mentees. You're allowed to make a mistake. That's what you're here for. You're learning medicine. You're not practicing medicine. So we give them a skill lab where they are allowed to practice as many times, but they need to know that if they're doing a particular procedure, what are the steps that they're doing it with? And they should be able to get the feedback that whether they have done it correctly or not. So whenever you are doing a particular act of simulation, it is divided into parts. It's called a pre-briefing, the scenario, and the debriefing. It's simple. We've done most of it. For example, if I have to do a scenario of an emergency patient coming to me with epistaxis, what should I do with the pre-brief? Friends, once again, as we know, all of us as educationists, the fundamental aspect of designing any particular module are the learning objectives. What is the first thing I do? What are the level of my learners? Are they medical graduates? Are they medical interns? Are they medical postgraduates? What am I supposed to teach them out of this epistaxis scenario? It's just not, okay, I decide to do a scenario for any particular simulated act and I go ahead to do with it. No. As you get down to do your module, my first question to myself is, what are my level of learners? My second question to myself is, what are my going to be my learning objectives? I define my learning objectives. And there and then, friends, I know if these are my learning objectives, I would have a set of pre-briefing to do. I would share some documentation with the mentee group. I would share a video with them. Not only that, I would tell them, where are you going to do the simulation? It's going to be in the next building on the 5th floor, or it's going to be on a block away, it's going to be on a different hospital. They need to know where they are coming for the simulation. That's very important as a part of the psychological safety measure. I tell them that. I can share them a video of my skill lab also. Once they are done with that, then we come to the actual scenario where you may have the act being performed by certain actors, which in our terminology of the paradise world, I called as simulated patient or an embedded participant. So I have a wheelchair coming with a patient and an attender. And from this patient, I have blood-like substance falling. Technically, this is called as mileage. And how do I create that? Simple. I had my students devise the method. Something like simple as sugar mixed with some color could just look like mileage. We went on to do an exercise with our nursing students. We did a mileage competition and came up with innovative ideas. You can have your own. This walks in. The patient is then received by the nursing staff, put on the couch, and we start with the checklist of doing the treatment for epistaxis. So the scenario for simulated act of epistaxis is being conducted. It's conducted and very well conducted. It takes about odd 15-20 minutes, went on well. Then my students gather and they ask me, ma'am, what next? So I tell them debriefing. Debriefing, friends, the first principle that we follow: never debrief in the same room where the simulation has been carried out. It's very important to take your mentees onto a different room, which is away from the room of the simulation where the debriefing is going to happen. Second point, how long should the debriefing session be? Friends, as per the literature, ma'am, I will get back to that. Ma'am, when you are doing a simulation scenario, your student has moved mentally onto the scenario where this is happening. Let me give you an example of a cardiopulmonary. Say, suppose patient had cardiac arrest and the patient has desaturated, patient has died during the scenario. Now, this particular student who was participating, maybe 4 or 5 of them or one of them, has probably had a similar incident where he lost a family member, somebody with similar event. The student moves into the zone. It is very important for us to get our students out of the frame of simulation to get them onto debriefing, because you cannot have a successful debriefing till you have moved them out of the frame of the simulated room. Once you have done that, you will make them sit not in the manner of maybe lines one across, the normal sitting arrangement that we are following. It's almost like a circle, and you start. Again, I'm back to Jurassic Park. The first part of debriefing is always reaction. How did you feel when you watched Jurassic Park? Well, I felt it was fantasy. I felt how different it would have been, where there were no human beings and different creatures which looked much bigger than us. So we move into you are getting them out of the frame, friends. This answers a part of what we were talking about. So you get them out and you said, what is your reaction? Somebody says uncomfortable. Somebody feels, I felt confident. Somebody says, no, I'm still not confident, ma'am. Somebody says, ma'am, maybe we can do it again. Or maybe I missed out on a step. Okay, no issues. We go on to the next. We come on to analyzing of what happened. Now, this analytical phase of the debriefing has numerous technical terms of how to deliver it. One, which is advocated as a part of the Harvard Medical School, is called advocacy inquiry, which is wonderful, is all over the web. And the second, which is the plus delta. I love the advocacy inquiry. I started doing advocacy inquiry on myself. This is a secret that I'm sharing on the webinar. So what is advocacy inquiry? Advocacy inquiry is that you talk to your student, you talk to them. For example, let's take epistaxis again. So I saw that you put the nasal pack on the right side of the nasal cavity without inspecting the nasal cavity. I feel that when you were putting the pack without seeing or inspecting the nasal cavity, you could have injured the middle turbinate, leading to a CSF leak. But you need to understand that what the student was thinking. And that is the next part. That is inquiry, that why did you do that? You need to ask him, why did you do that? You saw, you thought, but what did the student think? So he will probably answer. He will say, ma'am, I probably thought that the nasal cavity wasn't needed to be inspected when I had already seen it before I made the patient lie down on the couch. So you will have to tell him that this is also an important aspect. So advocacy inquiry is in 3 parts. And finally, the last part, which is the summary, you summarize your debriefing and you tell them that these were the takeaways which can be implemented in the next simulation session that you carry out. The next slide, please. Sakina, the next slide, please. Okay, so you can go ahead with these slides because I've summarized it on a particular slide. The next slide, please. I've covered this as well. Next one, please. Yes, the next one. Okay, now we come on to this. So, okay, we carried out simulation and we all agree that we were able to deliver, learn with, from, and about each other of a team with the use of simulation. My first question is that my first objective that I wrote down What was the need of an interprofessional collaborative practice module within your curriculum through simulation? You need to understand which is that area of your curriculum. You need to carry out a needs assessment and then go on to the step of developing this particular module that we have all done together today. The part which is, as we all know, assessment drives learning, which is the absolute core of any particular health profession education system. So you need to assess. And I think the most beautiful way to assess simulation is we carry out team OSCEs. We do carry that. We use reflective cards, which we use for them. We know this is the particular, we have the Miller's pyramid here, which shows different aspect, knows how, shows and does. Well, interestingly, we have had a lot of projects moving on to workplace assessment, but we are going to share the work very briefly. But we want all of us, if you have interprofessional collaborative practice module in your system, take it to the next level, discuss it, share it. Let's come to collaborative learning to improve healthcare. The next slide, please. Okay, now these are our experiences. I would share them very briefly and I will not detail them. The first part was, I think, which Dr. Seo would know a lot with me because she is my co-fellow from Mahe Fama, is my interprofessional collaborative practice module on tracheostomy. So this particular work we had done during the COVID times, and I will share the experience which touched my heart. Some of our students who were a part of this particular pilot, they were also doing the COVID-19 duties. So when they came back, after doing a part of the module, they shared with us. They said, ma'am, we felt more confident doing the tracheostomy. And we all understand that performing a tracheostomy during the COVID-19 was one of the most challenging acts because you were rather, the chances of getting infected, the chances of various other chances were very, very high. So we were able to give them the confidence just with part of the module. So this was one aspect which finally we published the article, we made it a part of our institutional program, and we have presented it at various conferences and being able to lucky and blessed to have won the first prize always. That was one aspect, but we didn't stop on that. And we know as all family, we go on to develop what are we going to do next. We have to improve, we have to deliver more programs to the society. And that's what ERA University stands for. We are here to serve the community. So we went on to develop grand rounds. I spoke to my team and I said that we will be having one grand round once a month on one topic in ENT. But this round is not going to be led by the ENT surgeons. It's going to be led by the nursing staff. It's going to be led by the allied, by the audiologist. It's going to have topics like hearing loss, topics like chronic otitis media, topics like vertigo, topics like tinnitus. And we are able to implement it. And on certain special days where we are increasing the community, I would say, awareness, like hearing loss days, hearing loss programs are being, I would say, implemented. We're doing this. So second aspect was an interprofessional collaborative rounds. We did not stop there. We went on to do another aspect. We went on to the schools around our institute where we are carrying out projects for improving hearing loss incidents by interprofessional collaborative approach. And here, in our stakeholders, besides the medical doctors, nursing staff, allied, we have the parents. They are a very important part of your team. We have the students themselves being part of the team, where we are delivering these programs together. Friends, my take-home message for this particular webinar for all of us today is interprofessional collaborative practice is the need of the hour. I heard a beautiful webinar by Hardin sir, and he said COVID-19 was the most challenging time in the health profession education paradigm. However, it has been a silver lining because we have moved maybe 2 decades ahead and we realize the importance of working in a team. And to use that, we have simulation. Simulation can have various modalities, friends. It could be just a room. It could be a skill lab. It could be a fidelity mannequin. It could be virtual reality, augmented reality, enhanced reality. I did not touch that because interestingly, before I started the webinar, which would be my concluding lines, I went on to ChatGPT this afternoon And I just put in, what are the clues to develop the healthcare professional team for facing another pandemic? And the first line ChatGPT gave me, friends, was collaborative practice. So we have it: virtual reality, augmented reality, mixed reality, and AI is here to stay, but not without empathy, not without your critical thinking, friends. So let's get on our dancing shoes and implement interprofessional collaborative practice with simulation. Thank you very much, Zedi sir. Thank you, Era University, Sivu. And I would conclude this webinar with my sincere acknowledgements to my mentors, Dr. Farzana Mehndi Madam, Dr. Sucheta Dandekar, Dr. Nirmala Regge Madam, who has held my hand always and all through, Dr. Siraj and Dr. John Gilbert, sir, my mentor from the Malaysian University of Mahe in Malacca, Dr. Sumain Sahu. Thank you very much. We are extremely lucky and blessed to have mentors like you. Thank you very much, everybody, and have a wonderful day or evening, depending on which part of the world you are. Stay safe and stay blessed. Thank you, Sakina. It's about you.
Sakina, do you want to, would you permit me to interact and then start debates? And we have discussed, we have fundamentally, well, we've got loads of scholars. I mean, they know much more than I do. So do I have your permission, Sakina?
Yes, go ahead, please.
Thank
Absolutely.
you. So let me just compliment you, Anuja, for a wonderful talk on a very, very important subject. I mean, interprofessional education is new to us. I mean, in my days when I was young and I was doing all these things, interprofessional education, I mean, medical education did not exist. It was only much later that we realized. Interprofessional education and collaborative education is the name of the game. You gave a wonderful example of tracheostomy, and I'll quote my personal example. Once I was doing a tracheostomy in Liverpool some 20 years ago. In the middle of the night, a fat, ugly man who had been comatose for 6 months or so. Suddenly, I got a call in the middle of the night to go and do a trachea. Now, in UK, the problem is, unlike India and Pakistan and subcontinent, you don't have any assistance. You're on your own. The registrars, busy, and SHOs do not exist. So can you imagine that the misery, the challenge? Fat man with huge neck, comatose, tracheostomy in the middle of the night. I mean, it's anybody's nightmare. Anybody's nightmare. So the anesthetist said that, well, I'm looking through the hole. What I can see is nothing except darkness. What do you think? I said, it's darkness, but I'll manage. So what I did was I followed the classical steps and asked one of the junior nurses who happened to be around to come and assist me. Because, you need assistance. Tracheostomy is never taken a mild up. It's a serious professional, it could be a serious professional hazard. So that nurse, and then she became a regular visitor. She used to come to outpatient, etc. So the point I'm making is that you need interprofessional nurse, doctor, physician, anybody. We cannot survive in this world as a solitary, lonely person. That's the first thing. Second thing, you mentioned very nicely about certain steps that one should take in life, and you get the example of the Miller's Pyramid, which is conventional to all of us, those who've been in medical education. What I'd like to add here is that nothing beats experiential learning. And I think the definition that you gave, experiential learning, is not just theory, that's there. Applied knowledge is equally or perhaps more valuable. So there is a wisdom, formula of wisdom. Wisdom is different to knowledge. Wisdom is different to intelligence is being able to cope with circumstances. Wisdom is where you cobwebs of all the knowledge that's there, you dispense with them and learn and use that experience for experiential learning in the future. Now, what I see here is Majabeen Fayaz, who was there last week. She did a wonderful webinar. Her webinar almost matches with you. She was mostly talking about theoretical aspects. You gave wonderful examples of applied. Could I ask Jabeen to interact, perhaps? Would you like to say something, Jabeen?
Thank you so much, Dr. Zadi and Prof, who has given a wonderful talk on IPE. I
Anuja,
would
call her
say
Anuja. Anuja.
Anuja, yes, Professor Anuja. I think I agree what Anuja said. Um, I always see this lacking that there's a lot of focus in our countries, and when I say back home countries, is my Pakistan, and the same is when I work with India and many other countries like Bangladesh, Sri Lanka, Egypt, etc. There's a lot of emphasis on physician knowledge separately, nurses knowledge separately, and other professions learning separately. But like when we are working together, we cannot work separately. We have to work together in any situation, whether that situation is taking care of a tracheostomy patient, taking care of a patient who come in arrest, or any procedure. So I always say to my colleagues whenever I'm in such gatherings that why don't we provide them opportunities to learn together as well. Like when I started my house job, I did not even know how to what the nurses does, how can I interact with them in a way that we mimic a team. So yes, we know how the team work, but the functionality of teams work is only be evident when we do such sessions, and simulation is one of the way, in many other ways. So a lot of, like, even in our institute we do almost 40% of our sessions are interprofessional sessions, so which will enforce that why the interprofessional education is important. And I agree with you, Sir Zadi, that yes, like theoretical knowledge is important, but then how you apply. And it could be as simple as like just before your shift or before when you go, just getting your team together, having a small team huddles can be a part of your simulation, that how we are going to work, who is going to perform that. So this is called a just in time training. So these are some of the views that were coming to my mind when I'm listening to Professor Anuja's talk.
Do you want to respond, Anuja?
Yes, sir. Thank you so much. Thank you, Jabin. Actually, I unfortunately missed your webinar, but I was only lucky to see the compliments. So I was really, actually, I was thankful to sir that it was lined up before this particular webinar, because I think they are actually working together. So what actually, interestingly, I would tell you, Jabin, when I went on to do simulation from SHS, I realized that we're talking about accreditation aspects. We are talking about
Mm,
getting a simulation center which should be accredited with the SSH and or with any particular council when you're talking about that. But as you very well said, instead of just having the theoretical knowledge, instead of just making a simulation center only to get the
exactly.
accreditation, the need of the hour is you utilize the simulation center to develop a simple program to deliver interprofessional collaborative practice, which leads to improved community health care. And not only, I think, Jabin, I had a discussion with some gentlemen in a part of Canada. And I always felt, as you very well said, that there are certain aspects which are challenging to the subcontinent,
Mm,
which we all are able to relate to. But I don't think so. I feel there are a lot of things which are challenging even in the developed part of the world, including
exactly.
US.
Exactly. I completely echo.
Only the terminology of the challenge changes.
Mm,
From here to a communicable diseases, it changes into addiction.
mm,
It could be excessive use of morphine. It could be excessive
exactly.
use of opioid. As simple as that. So the point is the principle should be there. So you develop simple modules as advocates, and I think move ahead, give it to people. And I would like to, discuss with you on this, and I will be
Exactly.
working with you. And I would really request that we work in collaboration, a lot of work together. And
Yeah.
that's what I think Zaidi sir has been putting, this message across to me. He tells me the world is all together. So it's just
I
like we're
completely
connected
agree.
all the time.
Yeah.
So that's something which is put into my soul now, that I'm where I am. We're all together and we have to come to a solution that we can help the society in whichever the part of the world we are. And some part which somebody has put on a discussion chat, how do we deal with big batches and interprofessional collaborative? I think Jabin will agree with me. As a part of the SSH training, it says that when you are doing an interprofessional simulation act, you need to have group of interprofessional mentors as well. So what you do is you make a kind of a roster within your system. So you'll have to develop a module, how you integrate it into the curriculum, and it is done over a period of time. So it will be a small group ultimately. And how would you do that? So you make your community of practice, something which family, we all agree to that. We are a community of practice. You have to have a community. And to be a community of practice, you don't have to be a farmer. You don't have to be a master's in health profession education. You don't have to go and do a certification from somewhere. You can be with your passion. And that's why I call it's paradise. If you know
I
how to know your
completely
passion,
agree.
you can do it.
I like
And
this.
Anuja, you bring, oh, sorry, sir, go ahead.
No, I was just saying, I like the birds of paradise around here.
Hmm. And then I think Anuja bring up a very important point, which I always hear. We do not have a sim lab. How can we do a simulation? So I always say simulation program and simulation lab or sim center are two different things. You can still have a very robust sim program without having a very well developed or well defined sim space or simulation lab that people call it very often. It's just a methodology how you will educate your teams and your team member, and sim lab enable you to have a dedicated space to conduct all those things. But as Anuja is alluding to, a simple seminar room developed intentionally for sim activities can be used to teach or to have a sim program. We have a two-roomed space, and we are doing the sim program in Canada, I'm talking about, from 2009. In Indus Hospital, they just have a very small seminar room that they are using for sim activities from 2019. And for 6 years, they are doing all these sim activities, and they have a well developed sim program. But yes, the sim center or sim lab is still work in progress. So that misconception I really want to, because it hurts me that people think they cannot do anything because there's no sim lab, and there will be not enough resources ever or always for creating a sim lab in many spaces.
Thank you. So Mona has a question. Mona is a regular attendee and participant. Mona, do you want to unmute yourself and ask the question about online session? Unmute, please.
Yes, can you hear me now?
Yes.
Okay.
Yes.
First of all, I'd like to thank Professor Anuja very much for your very insightful and informative presentation. Yes, I was asking about the possibility to implement simulation sessions online. Is it possible? Thank you.
Thank you so much, Mona. And sir, can I take this question?
Yes, of course.
Thank you so much, sir. Mona, I think that's very interesting. I would share that. We went on to start simulation with a small, I would give an incidence. I think Zeddy sir will relate to that. For anterior nasal packing, when I started my teaching career, again, I mean, I did it in phases in 2012. So I wanted to teach my students anterior nasal packing. I didn't know what to do. That time, that was way back. I had a mannequin. But I thought that to get the mannequin, it was in the sim lab. Javeen would relate to that. I said, what should I do? I said, let me create a nose. How do I create a nose? So first vegetable that came into my mind was a pumpkin. So to get a pumpkin, I carved out a nose in my at my residence, and I tried to pack the nose. But I felt that the feel of the pumpkin was little more firm than the feel that I get when I pack the nasal cavity. So I took something as simple as the bottle guard. It may come as different shapes in different parts of the world, but the simple bottle guard, I carved out nasal cavity for my group of students, and they started packing the nasal cavity. And I was very fascinated to see their interest, Mona. You know, what we used to do is to tell them, go downstairs, fetch the bottle guards, get it up. And now it's been almost 10 years, 12 years to now. When I see them across, they become young faculty members and they say, ma'am, we know how to do the nasal packing because we did it on the bottle guard. It was not that they did it on the bottle guard, but they have the frame of doing the nasal packing. Now, getting back to what happened in 2019, we all know that. So when we came, the entire thing came to a big halt. And then they gave us the challenge that, okay, now teach the skills. So we thought again, let's make use of the bottle guard. So we started using things which were indigenous once again, commonly available within your premise of your home to practice the skill. It could be a lemon, it could be an orange. And when the students were within the COVID-19 period, they didn't have many things. They had simple things like a forceps. So we used to tell them, okay, just pick up a forceps that you have and try to take a roller gauze that you have, take some toothpaste, put it into a bowl, that becomes a medicated nasal pack. And then try to put it in the bottle guard. And we had our Honorable Pro Vice Chancellor completely supporting us. We had the system integrated within our rooms where we were sitting, and all of us were sitting in rooms. And interestingly, the rooms were silos because we were not supposed to see each other. So the entire department, but in different rooms, students within their respective homes trying to do anterior nasal packing together. And we were able to do that. So my point to you is a simple takeaway. First, you see what is your learning objective. It could be very simple. Once you know your learning objective, you think, what do I need for that? It could be something which is innovative, and you have the world to yourself. You can search whatever you like, search it, use it, and then deliver it. You don't have to be in person to create the reality. Believe me, it's just the magic of experiential learning. You can do it the way you like. I hope I've been able to answer some bit of it.
Oh, fantastic. More than answer. Anyone else would like to unmute? Go ahead. Anybody?
Sir, can I add something here?
Yes, of course, Javeen.
Yeah, so thank you, Anuja, for that example. I would also like to say to Mona that the same thing happened with us, similar kind of story. And we did not like stop there because sometime having international facilitators to travel and even the learners is a issue. So how did we sorted it out is through virtual simulations. There are many platforms which are easily available, low cost solution for such trainings, and we are using it since 2019 even for training pediatric emergency medicine physicians. So why I'm giving an example of emergency medicine, because it's an acute care specialty, there's always many skills that are expected. So we are using those virtual platforms. Please reach out to Anuja or and me, and we are happy to tell you more about it. So the short answer is yes, it is a possibility, and it all depends on your learning objective and what learning outcomes you are looking at.
So could I say that perhaps at some stage, Sakina can organize a workshop with both of you, teaching the audience and the participants with practical steps?
Yeah.
Is that a possibility?
That will be wonderful. We use
Wonderful,
a virtual
sir.
recitation
Absolutely.
room. Oh, sorry.
Yeah.
Go ahead, Anuja.
No, please, Jabin, take it.
Yeah, we use virtual recitation room platform and ASIP Symbox, as well as there is one virtual gaming simulation platform which is developed in Canada, but there's a free version, Affinity Learning, to create virtual gaming simulation. I'm happy they may not fit in one workshop, but I will coordinate with Anuja and we can come up with some kind of workshop where we can show one or two examples, and then whatever the interest of the learners are, we can take it more forward.
So there'll be a perfect combination, because one from the developed country and one for the developing from India and Canada, and of course CV is at your service. May I request, Sakina, if you could perhaps make a note and find a slot sometime, whenever it's convenient, maybe 2 workshops, hands-on workshop, not a webinar. You can teach the participants how to do these things.
Yes.
Sakina, kindly.
Absolutely. I will definitely.
Thank you so much.
Yes.
Sir, can I have your permission to add a line, please?
Yes, of course. Don't need permission at all.
Of course I do, sir. I really enjoy taking that permission, actually.
Thank you.
So something to what
You've
Jabin
already
said.
made me
Thank
Jurassic. You already made me Jurassic Park character. So yeah.
No, sir. No, definitely not. Definitely
All
not.
right.
No. So something that Jabeen wonderfully explained, we do have wonderful platforms for having virtual reality, virtual patients. What I love about virtual reality is what it doesn't have. All over the world, I see how we cannot, I mean, AI is here to stay. If we do not imbibe AI, we will perish. We have to take an imbibe. And I read not a lot, every day I'm reading, I'm extensively researching onto that what happens in 2050, what are the people who are going to be left with without working without AI. But what I am looking now is something which I think only simulationists who are passionate look for. What do virtual reality platforms don't have? So what I feel they don't have is, I feel, the frame, the ability to shift you there. I tried it on myself. I just did a, particular exercise where I took a virtual reality where I had a virtual patient talking to me with abdominal pain. And I took myself to the frame where I saw the same thing when I was in medical school. Did I experience the same? I felt no. The question is that the student or the mentee that I am training is, will he be having both of them or either of them? So as Jabeen said, definitely in particular part of the world, we have only a particular kind of a clinical experience, which is virtual now. But in this country that we live in, the subcontinent, we are able to give them the experience with the patient. Now the question arises, where does a virtual reality fit in this kind of a curriculum? So something wonderfully, which is again from my friend philosopher guy, Dr. Prasanna Mendi, and she calls it layering. She's given me that concept. She said nothing in isolation. So what we do in our university, Jabeen and all my dear friends, we have a gamification center developed by our chancellor. We have bronchoscopy sessions, which is in the form of a game where the student can enter into the scenario as a virtual reality, but we do it as layering. So it goes on from part mannequin to a full body mannequin, going to practice sessions, ultimately going to gamification. And coming back again to something fundamentals given from Harvard, you have 3 sim zones. First, you do the particular skill in isolation, for example, urinary catheter insertion. Then you do it within a scenario, patient coming to you with obstruction. And third, you do it within a team. So it is a build-up of your social framework. The question arises, what is available to you? The patient in reality, or are you creating the virtual reality? So the take would be yours. Thank you.
How interesting. See, it seems that you both are collaborating without knowing each other. Just while we were discussing earlier on, Javeen sent me a message. So, wanting to talk about AI and simulation and gamification and gaming simulation. How wonderful. So, like minds, the great minds think alike. You can think about it. And perhaps we can close the session on the words of famous Ronnie Harden from the same university that I went to, that's Dundee, that out of the black and evil cloud of COVID-19, there was a silver lining. We've snatched out of it in the form of online seminars, webinars, and workshops. And this is a wonderful world that we're living in. Technology is wonderful. I'd like to just mention here that recently I came across a new AI tool called Perplexity. I don't know whether you use it or not. Perplexity not only gives you the resources, but also gives the citations of genuine, authentic references. Perplexity. Please try it out. On that note, over to Sakina.
Okay. Thank you, everyone. This was a wonderful and very interactive session. I really enjoyed it. And I hope everybody else did too. And thank you very much, Anuja, and Jabeen. This was a very interesting topic for me, who is not medical. You know, I have no medical background, so this was very interesting. And I thank everyone for joining. And please don't forget to add your name for the certificate. And thank you. I will see you all next week. Thank you.